Well, thank you very much for joining us. Hopefully everybody didn't have trouble signing in and has access to the articles. Steve put them in the link. So those of you who didn't receive the articles, please log in there. So my name is Eric Wagner, and on behalf of myself and Chris Clifton, we'd like to welcome you to the first ASES Virtual Journal Club. It is our pleasure to be graced by the presence of Dr. Mark Frankel and Dr. John Sperling as our content experts on this first journal club focused at primary shoulder arthroplasty. We also are lucky enough to be joined by Brent Morris, Gabe Horniff, as well as multiple members from the Rothman group, Dr. Joseph Aboud, Jerry Williams. So with this journal club in the format, the idea is we're going to quickly go through the article. The idea is not necessarily to critique the article, but more so to stimulate discussion and learn from our moderators. Anybody who has a question, please feel free to chime in. Dr. Clifton will be allowing you either to ask it or we'll be helping to answer it as we go. Furthermore, any of the panelists will chime in as sort of or is necessary. So before we get started, I'd like to send a big thank you to both Zimmer Biomet as well as DePuy Synthes. They were gracious enough to sponsor this journal club and on very short notice, and we really appreciate their support in this. So without further ado, we're going to go ahead and start with our first article. So Steve, you can share that first article.
Just
Wonderful.
quickly, if anyone has any comments that they would like to, or questions, just put the raise hand sign in the attendee section and we'll get you to speak, or you can put in the chat and I'll ask the questions to the panelists.
Awesome, thanks, Chris. And yes, please feel free to speak up, as we want this to be as engaging as possible. So this first article, sort of one of the classics that's really kind of changed the landscape, particularly in America as well as around the world. So as many of you know who are very familiar with this article, this is a article looking at 60 patients, massive rotator cuff tears and glenohumeral arthritis. The technique involved a cemented humerus, a base plate with 3.5mm screws, and either a 25 or 29 glenosphere. Follow-up was 33 months, very good overall clinical outcomes, particularly for those that didn't have prior surgery, and no scapular notching was noted. One of the first articles of this kind to show a decrease in that common complication up until this point. 17% had complications, including 3 chromial fractures, 12% had revisions, including 6 conversions to reverses and 2 hemis. Of those that were revised to the reverses, they did quite well as opposed to the hemis. And so overall, this study, obviously it was a phenomenal study. It really changed the United States shoulder surgery for good and introduced the reverse prosthesis to the US. It also really clearly demonstrated, as multiple of these tables have shown, the advantages of the reverse over the hemiarthroplasty in this type of setting. And as figure 4 shows, it also kind of introduced this idea of glenoid lateralization, or glenoid and glenosphere lateralization, and how it has the potential to decrease bony impingement, decrease scapular notching, and really kind of approaching the shoulder's normal center of rotation. One other interesting conclusion that came then a couple years later was when Dr. Frankel and his group showed that by increasing the peripheral screws to a 5mm diameter instead of 3.5, they were markedly able to improve upon the rates of glenoid loosening seen in this sort of initial study. So as you can see, just a really, really interesting study. So from so many levels. So Dr. Frankel, we're going to start with you. Sort of as the driver of this classic study, and kind of somebody who's driven obviously many more since. Can you sort of talk about your takeaways back then, and now that you look back at it, some of the takeaways that you kind of learned now, and share with us some insight?
Sure. So one of the things is to give people a perspective. This article was published, I think, in 2005. And so that means these patients were collected well before then. I think the last patient in the study was in 2002. So all of these patients who were enrolled in who had this procedure did not have an FDA approved device. And one of my biggest fears, so in the 90s, it became clear to me that the hemiarthroplasty for these group of patients was not really working very well. And I was somewhat not inclined to think this is what we could do. And I was introduced by Gilles and some of the other French guys to the concept of reverse prostheses. And one of my fears was that this would not be adopted in the United States. So I really wanted to try to publish my early outcomes with this early group of patients to actually demonstrate that there was a possibility to really improve functional outcomes in what we used to think was not possible. So that was my mindset at the time. Now, some of the things that I overlooked probably was a little bit of a naivete, because I didn't think that the failure rate was that bad. And quite honestly, I didn't quite understand this idea about why everyone was so against lateralization of the glenosphere. And so the unexpected outcome of this study was, for the longest time, the idea of lateralizing on the glenosphere, this study was the best ammunition to argue against that principle, because it sort of strengthened what people commonly believed was the reason that reverse replacements would fail, is that moment arm leading to failure. And so in some ways, I think this set back something that I thought was evident to me, which is if you can do a reverse replacement and try to make the anatomy of the shoulder look a bit more normal, it's likely to have many, many benefits, including avoiding of notching, improvement of all sorts of things. And I still believe that that concept is germane today. So, you know, those would be my takeaways now thinking about that. You know, I guess I could have waited because I knew the issue of failure, and it really was something that drove us to try to make changes in the next design. As you mentioned, this device was introduced and designed before locking plates were produced. So the idea of a locking peripheral screw was novel to me. Now, I have to give Guermont a lot of credit because he actually had, in his Delta 3, had locked screws. And I don't know how he came up with that idea, because that was, you know, even well before any of the locked plates that we have now. But that was really novel, and it struck me that that probably accounted for his low failure rate on his initial Delta 3. They didn't have mechanical failure. And everyone attributed to the lateral offset, it probably had to do with the fact he had those two lock screws that were divergent that added substantial improvement of fixation. And so when we had the failure, I had in 2002, I think, when we started to really see this and try to stem it. And my fellow at the time had done a trauma fellowship. So we had discussed intensely the addition of locked peripheral screws. And it was not just the diameter of the screw, it was the locking of the screw, because, you know, the device uses a compression lag screw. And if it unturns, you lose compression. So if there's motion between the peripheral screws and the base plate, that can toggle, where when you have a lock screw, you can't. So those would be, I think, what happened next from this, that I think really the idea that a lateralized sphere does lead to increased failure, I think pretty hopefully that is no longer something that people think is very likely to occur.
Yeah, no, those are wonderful points. On the idea of lateralization, for the benefit of the residents and the fellows that are on, can you discuss just briefly, first off, why you feel lateralization is important? Do you think, as Atwell has suggested in some of his FEA, that there is an impact of lateralization on acromial fractures? And what is the future of lateralization as we kind of move forward?
Well, you know, so I guess the first thing is the idea of lateralization in my mind is just what I said initially. So when you talk about a reverse prosthesis, you know, you're talking about changing the articulation, but there's a lot of other things that previous designs also did with that, right? They changed the neck shaft angle. They took a sphere that the center was at the glenoid. And when you did that, you really changed the shape of the shoulder relatively dramatically. And, you know, that sort of bothered me. The other thing that bothered me that drove this really was So when I started doing shoulder arthroplasty, I thought I need to learn one operation. So I didn't want to have to do my reverses, cut them different, put them in differently than my anatomics. So the 135 neck shaft angle, that's what my anatomics were 30 degrees of retroversion was a cut, so it's the same cut. So principally, I wanted one operation that seemed the same because it made sense to me that we shouldn't have very different techniques when we do this. It just struck me as being, not really, it didn't make sense to me. It seemed like it would add some confusion and lead to a lack of predictable outcomes. And then, George's comment about every time I see George, I like to give him grief about the study because all he showed was that if you use his model of FEA, then you'll have increased stress of the deltoid on the acromion if you use a lateralized sphere compared to a medialized one, okay? But what he doesn't say is, well, what was that normal stress be in a normal shoulder? Because the fact that you have more stress, I mean, that was one of the things about that moment arm that was so popular that I completely think is erroneous and always gets us into trouble because the idea that there's a moment arm of the deltoid, sure, you can draw the model, but what about that only occurs depending upon where the scapula is. So, none of that, and part of what in that future article that we showed, it was sort of a comment back to George. It was really, that was our way of continuing the discussion and saying, wait a minute, I don't think what you said has evidence to support your conclusion. In fact, it's erroneous. So I don't see that. I think
Wonderful.
Dr. Frankel, we have some questions coming in for you. Maybe they're directed to you. We could just kind of quickly go over them. This is the first one's from Dr. Garaldi. He says, Mark, why do you go to a 2/3 sphere instead of a 1/3 sphere?
Well, I mean, part of it has to do with the fact that when you have a 2/3 sphere, you have that large arc of rotation without impingement, right? It necessitates that. And also what that allows to do is, once you have a greater arc, this was something that Mike Pearl brought up in anatomic shoulder replacement, is the arc of congruity of the humeral head. So you want to have as much arc of contact of your articular surfaces, because once you get to the edge, you start getting edge loading. So if you have a half sphere, even if you do a bi-RSA, once you get past that level of that hemisphere, you're going to get edge loading between the edge of the hemisphere and the poly. Whereas if you have a 2/3 of a sphere, you always have contact. You always have the smooth surfaces commenting. So you don't get that edge loading. So that would be why I think these type of ideas of 2/3 of a sphere as opposed to lateral build on a hemisphere are significantly superior.
Thank you. Dr. Hassan next has a question. He would like you to comment on the early use of implant as a custom device. He said it is one of the great stories in shoulder innovation.
Yeah, well, those would probably go into, I could never do that study now because I'm way too conservative and I probably would be, I just wouldn't be as audacious to do that now, or I probably wouldn't be as stupid to do that now. I mean, there are a lot of mistakes I made that turned out to work out well. I guess that probably has to do with many of the things that happened in our lives that at the time, it really worked out well. What I learned is if you're going to do a custom device, it's really one. And really the impetus of that is, so the FDA, the FDA doesn't allow companies to sort of get around an IDE process by using these custom devices as a surrogate as opposed to an IDE study. I can talk about the pros and cons of it, but I got an FDA warning letter right after this article came out. And I think the only reason I was not ready to really just be completely despondent was the DJO device got FDA approved right before that. And this article came out. And then I got the warning letter. So the warning letter was really bitter, but these things offset it because I thought we were making some strides.
Okay, I'm going to try and do something here. Ivan could you like to talk? Could you ask your question to Dr. Frankel and Dr. Sperling? Okay, maybe that didn't work. All right, so the next one's from Dr. McCollum. Says, do you change the amount of lateralization based on your perception of bone quality? If so, how do you change your lateralization?
Yes, well, that's a complicated question. I would say, part of one of the aspects of what I've learned is there's a lot of ways you can reduce the amount of force on your fixation. And I think the thing that I think is most effective is actually using a larger hemisphere or a glenosphere that overhangs the base plate that actually contacts the glenoid surface. So when you load the glenosphere, you get load sharing. And we've published on that and showed that. So, one of the thoughts was that lateralization lead to increased force at your fixation site, leading to this rocking horse idea. And I wasn't so convinced of that. And if that were the case, then you might go to a more medialized sphere when you were concerned about your bone quality. And when we tested these various different combinations in the lab, what we found by far and away a more effective way to reduce the load on your fixation was to have a larger glenosphere that overhang and hit the glenoid. If you look at the figure that's on the screen, you'll see that that glenosphere covers the glenoid exactly, the base plate exactly. So there's no possible load sharing of that glenosphere to the bone. So if you imagine a glenosphere that's much larger than the base plate that now contacts the host, when you load the glenosphere, it actually shares a load and shields some of the forces that might cause your fixation to fail.
Awesome. Thank you, Dr. Franco. So Dr. Sperling, real quick, can you talk to us about how your approach to the glenoid and the reverse has changed over the last 2 decades? And what is your current philosophy with regards to glenosphere side, lateralization, and, et cetera, some of the points that Dr. Franco brought up?
Yeah, I think Mark deserves a tremendous amount of credit. I think he was the one with this article and his teaching that showed us that the procedure can be reproducible. We can simplify the procedure, and then we can broaden the number of surgeons that can use this to help their patients. So Mark, I think, deserves a tremendous amount of credit. I think since that time, I think that there's lots of options available for surgeons. And I think that the pure concept of onlay and inlay actually today is probably not true. There's so many varieties, right, Eric? On the glenoid side, you can lateralize through bone graft. You can lateralize through an augment, which I do. On the humeral side, you can be onlay, but you can use a lateral offset tray that slightly medializes the humerus. So I think we have a lot more options available now to be able to help us. And I think for the fellows out there, it's just getting comfortable with whatever approach you want to be able to take to customize it for your patient. But this article is a classic, which Mark has contributed.
Awesome. Dr. Sperling, real quick, do you mind sort of expanding upon how you kind of make these decisions? What's your, obviously you mentioned your augment and you lateral with augment, and how you make the decisions with regards to, when to augment, when to lateralize,
yeah.
when to, how to choose your glenosphere size, your eccentricity, all that stuff?
I think that Pascal Boileau's article on the RSA angle is a very important article from April 2019. I know Tom DeQuinn and others started talking about it, but Pascal was the one who really showed us that there's 21 degrees of tilt from the inferior part of the glenoid. And putting that together with Mark's classic article showing us that we have to get back to neutral inclination means that we have to get rid of that central and inferior bone. And Pascal really was the one who pointed that out. So for me, rather than reaming away that bone now or using graft like Pascal, I use an augment, but there's lots of different ways to skin the cat, Eric. So I think there's a variety of different options that folks have available. I looked at Howard Routman's article earlier today. He reported on 4,000 reversals. Incredible. Scapular fracture rate, 1.77% with an onlay humerus. And you compare that to the article that we're going to go over later, that is a 13% rate with an onlay humerus. What that shows you is there's lots of different ways to mix and match things to get different results with reverse.
Absolutely. No, I couldn't be, that's the beauty of this prosthesis, and that's the beauty of these, both of you, and the contributions you both made to us. Any other comments from any of the panelists or the moderators before we go on to the next article? Wonderful, awesome. So Dr. Clitto, you can present the next article.
Pleasure. And thank you for all the questions from the group. They've been great, and we'll try and get to them as quickly as many as possible. I'll try and be brief with this presentation. So the next study is the survival of the glenoid component in shoulder arthroplasty, and this is from the Mayo group and Dr. Sperling. So the study was conducted to determine the survival of different glenoid component designs and to assess for the need for revision surgery, identify patient and diagnostic factors that influence this need. So this was a prospective registry cohort that analyzed 6 types of glenoid components: the near to all polyethylene, the near to metal-backed, the co-field 1 metal-backed bone ingrowth, the co-field 1 all polykeeled, the co-field 2 all polykeeled, and the co-field 2 all polypegged. Patients were prospectively followed at the 1 to 5 year mark. Kaplan-Meier analysis was conducted to estimate the implant survival and removal of revision of the glenoid component for all reasons. So the results showed that the revisions were required for 125 shoulders for glenoid, 125 shoulders for glenoid component failure. Survival rate free of revision of glenoid implants type at 5, 10, and 15 years were retrospectively reviewed, and they found that 96%, 96%, 95%, and 99% for near all polys. They found 96, 94%, 89% for 316 near to metal backed, 86%, 79%, 67% for 316 co-field 1 metal backed, 94%, 94%, 87% for 18 co-field 1 all polys, 99%, 94%, 89% for 497 co-field 2 all poly keeled, 99% at 5 years for 358 co-field 2 all poly pegged. They found that glenoid component type was significantly associated with component revision. Male gender was also associated with a higher risk for revision as well. They found that compared to degenerative arthritis, post-traumatic arthritis, and avascular necrosis were also associated with revision. So my question for Dr. Sperling and Dr. Frankel would be, you both have so much experience with, and most likely revisions for all these glenoid components. Would you both be able to comment on your observation of these components over the years?
I think my conclusion to this, and I give Bob Cofield the credit for this, he was the one who drove this paper. And I think in the current times, with the popularity of reverse arthroplasty, this is a nice balance to it. If you look at the durability, if you avoid a fully metal back glenoid component, the survivorship was 92% at 15 years. So it's a great operation still. Yes, the reverse is faster to do, it's easier to do, technically less difficult to do, but the anatomic has a very important place. I know from my practice, this article has influence because whenever I have the opportunity where I can do an anatomic total shoulder in a patient, I try to do an anatomic total shoulder in that patient. Love to get Mark's thoughts on that.
Well, so this is a conflict of interest, I'd say. So I have a Bob Cofield total shoulder. I think it's about 18 years on my left side. So I can say durable. My left shoulder is really quite good. It's not as good as it was at 10 years, but any of those people who know me, I'm fairly active, and this has really allowed me to maintain a fairly active lifestyle. I can sleep on my shoulder at night. I can do most activities that I choose to, and that's 18 years later. And I would say if you wanted a poster child for this article, I'm it. And I would echo John's sentiment that an anatomic total shoulder with the all polyethylene glenoid with meticulous technique is a really great operation. And I think we're all of us who have an interest in this think that we still want to try to improve upon it, but these are really great outcomes, and we should be mindful of that whenever we talk about the next innovation.
That's wonderful. Dr. Sperling, can you comment or at least teach to the residents of fellows a couple of the subtleties about this article. So why did the metal back components not work as well as all poly, and how vast majority of us use all poly now, and your comments on or your thoughts on keeled versus pegged and some of those kind of subtleties?
Yeah, it's a great question, Eric. We continue to see some of these things cycle back. So no one really has been able to make a fully metal back glenoid component work. And I think because of multiple issues. One, if you have the thickness of the metal, the poly tends to be thinner. You tend to get more accelerated wear of plastic when it's fully against metal itself. So you get the accelerated polyethylene wear, which can lead to instability or subluxation, which leads to even more accelerated poly wear. So that's been the reason. And this article did also early on start to give the picture also that peg components were better than keels in terms of survivorship. So I think those are the two key messages that came out of this article. Again, love to get Mark's thoughts on that.
Yeah, I would agree with that. I don't know that I have other comments other than the fact that when you look at anatomic total shoulder and you say what's the most common need for revision, typically it's cuff failure and then glenoid loosening, and depending on which article you read, those go back and forth. So because orthopedics tend to like to think about mechanical solutions, loosening could be improved if you get rid of cement and have an ingrowth surface. So the appeal of having a metal back glenoid, I think that's probably why Bob went down that pathway. Unfortunately, as John said, there are more things complicated about this than just that, and so that might eventually provide a better outcome. And again, I think that's probably the thing we have to try to innovate around. But right now, I still think that the gold standard is this.
So first question. First question is from Grant Garagos, thanks Grant for all your help putting this together. You were super influential as well. As a follow-up to that question, Dr. Frankel, do you think eventually metal back anatomics will eventually outperform all polys?
Well, it's going to have to be a significant iterative change.
I think the issue is when you get that it's fully metal back, I think that's the issue. And trying to balance that with full polyethylene thickness. Again, Howard Routman, who's very busy, and others have shown with a hybrid fixation that if you have some porous ingrowth metal, but not fully on the back surface, that you can get long-term bone growing in there. The issue is when you get that full metal backing, I think that's really a challenge. And it can also be a challenge then, of course, on the revision side. So I think for a lot of us, again, whenever we have the opportunity in our patients, for me personally, in their 70s and 80s even, if they have a good rotator cuff with minimal glenoid wear, I'm thinking about doing an anatomic total shoulder in that patient.
Dr. Sperling, the next question is from your partner, Dr. Sanchez-Sotelo. Can Dr. Frankel and Dr. Sperling elaborate on what they envision might improve the survival of anatomic glenoid components even further? Alternative materials or cementless ever?
I would say alternative bearing surfaces that I think would provide a possible improvement, while allowing you to get really stable fixation that we have with metal backing without having to increase the thickness of the component to accommodate polyethylene. I mean, polyethylene wear properties really start to change as it gets thinner on concave surfaces. So if you can deal with that, I think we might be able to really improve this issue.
Yeah, my sense is that even the all poly glenoid with that advanced polyethylene has done very well for a long period of time. I think the challenge now is the placement of the component, making sure we get rid of those outliers, whatever technique you want to be able to use. So at the time of surgery, you're able to go ahead and be able to put that glenoid component in your preferred position.
That's awesome. Can you, Dr. Sperling and Dr. Frankel?
Ask Dr. Frankel and Dr. Sperling what he does with an 80-year-old. Oh, sorry, Dr. Levine asked, 80-year-old female with a normal rotator cuff. Do you do an anatomic, TSA, or reverse?
Anatomic.
So I was about to answer that. I would probably say anatomic butt. And some of the variations would be, if it's a dominant arm, she lives by herself and she's independent, and let's say she has some other comorbidities, I might be thinking about a reverse because I'm less worried about subscapular failure. But if everything is, healthy and it's concentric wear, I'm going to do an anatomic as well.
Wonderful question. Real quick, so expanding on some comments you made earlier, both Dr. Spring and Dr. Frankel, can you give the resident fellows and everybody else listening some of your maybe one or two most important technical tips on how to put in the perfect glenoid that will optimize its longevity? Like, what are certain things that you really emphasize when you're teaching this to somebody else?
So
I would say, go ahead, Mark, please. Go ahead.
I would just say that shoulder arthroplasty is a soft tissue operation. And I think that one of the challenges that we face when we try to teach and communicate, we talk about the bony surfaces because they're much easier for us to discuss as opposed to the soft tissues. And there's an article that Bob wrote about revision shoulder replacement, and it was long, long ago. And there was a letter to the editor by Bobby Bunker, who's an English shoulder surgeon, who said, we were surprised at how good the outcomes of motion were. And he was asking Bob whether or not they were talking about abduction in the same plane. And Bob's answer was classic Bob. He sort of said, yeah, we were surprised about how good the motion is. And we think it has to do with the fact that we are very diligent about excising the hypertrophic inferior capsule. And I would say that step of the operation, excising the hypertrophic inferior capsule, I think is a critical component of getting your shoulder to balance. Because you can put in rock solid components, but if they're wearing asymmetrically or they're tight, you're going to have asymmetric wear issues that I think will affect your durability. And I would just give homage to Bob because I think that to me is one of the critical things I've always learned from him as a shoulder surgeon.
Next question is from.
I would.
Oh, sorry. Go ahead, Doctor.
I would agree with what. Yeah, I would agree completely with Mark. I would say for the fellows, the key is glenoid exposure and making sure that you're comfortable that you get a direct shot at the glenoid. Once you get to the glenoid, understanding the imaging studies so you're not fooled. So you understand and you get that backstage pass. You've either planned the case through computer software or CT scans, so there are no surprises. So you have the view you want and you can prepare it and place it the way you want.
Dr. Hartzler would like to ask the panelist's opinion on inlay glenoid components, and do they have indications?
Why don't you ask some of the other panels what they think?
Yeah, Dr. Williams. Dr. Williams, do you want to?
Well, I mean, the advantage of inlay glenoid components that have been shown in the time zero studies is that they have, they're a little more stable. You put the glenoid in the bone as opposed to on the bone. There are better wear characteristics potentially, and there's better time zero stability. I do use them I use them in two situations. One, which is the one we wrote about first, was patients who have really no bone left. I think they have pretty good rotator cuff, but I think their bone is insufficient for a standard glenoid, and I think that Anatomic is better in reverse. At least that's the patient that I'm thinking about. That was the first patient that we used it in. The second group of patients is younger patients that may be a little bit more active and need to have their glenoid last longer. So those are the two patients that I use it in. Of the 300 that I do a year, probably 20 are inlays.
Wonderful, thank you. Dr. Abood, do you want to quickly give your 2 cents on one, maybe a technical tip or two for the fellows, and two, when you're approaching the glenoid and deciding the component type, what are some of the more critical considerations that you feel are appropriate?
I would echo some of the previous comments already made, which is there's a soft tissue operation. You want to make sure you have excellent exposure. I think that's where people struggle, making sure they got full visualization of the glenoid, making sure that they have preoperative planning's become more and more important at this point to make sure where you're going to put things, and then making sure that you have full seating of your glenoid component on the back side and reaming appropriately. Those are probably three critical things. I do, like Mark said, I excise the capsule inferiorly. I think that's really, really important. Those are steps that I think a fellow can really work on diligently during their fellowship to get more comfortable at.
Fantastic. That's awesome. And for Dr. Garrigus or for Morris, anything else you'd like to add about sort of optimizing your glenoid component in the anatomic before we move on to the next article?
I think it's been said. I think the key comment was John Sperling's. I mean, it's all about the positioning. Really, you really want, excellent, backside coverage. You want excellent position with regard to version we talk about. We don't talk a lot about the inclination, and I think that's going to be an area that research is going to show probably does have some influence on the outcome. So, really getting that thorough preoperative imaging, scrutinizing it, and making sure that your component is well seated, well supported, and properly positioned.
Wonderful. Thank you. All right, Steve, can we move on to the next one? This is the humeral head restoration, comparing humeral head design. Yep, you're one from the left. Perfect. This is from our group, the Rothman group, who we're lucky enough to have multiple members that hopefully can give us some insight in both this article as well as their approach kind of going forward. So this is a very relevant topic today, as this sort of evolution of shorter stems and even stemless designs are kind of really taking foothold. Purpose of this was to look at humeral stem design lengths and its impact on ability to restore native humeral head anatomy. And the idea is if you can restore better anatomy, you can get better function. So this is a retrospective review over an 11-year period. They did exclude 52% of the stemless implants because of follow-up. Otherwise, the rest were included. Overall, their definition of acceptable native humeral anatomy was a center of rotation less than 3 millimeters, humeral head height less than 5 millimeters, and a neck shaft angle greater than 130 degrees. So overall, 261 were included, 31 stemless, 43 short stem, and 180 standard stem. There was no difference in center of rotation, although it was potentially slightly better with stemless. There's no difference in humeral head height, although it's potentially slightly better with the standard stems. And then really the main finding, the main significant factor was that the stemless were more likely to be placed in varus compared to the short stems or the standard stems. And this is consistent with some of the other studies that have found similar type of studies. So this is a really kind of interesting and provocative study. It stimulates and sort of contributes to the discussion about both stemless and stemmed implants. And although it would have been strengthened by clinical outcomes, it does show the potential disadvantages of stemless implants. And although there are many theoretical benefits to these stemless implants, it shows that potentially they might be more technically demanding and even surgeon dependent. But it is a really great foundation for comparing future studies of stemless and stem designs. And for the residents and fellows, some of the potential advantages for a stemless design or a short stem design is you preserve bone, potentially it's faster, potentially you have less blood loss, potentially it's easier revision. But there are some disadvantages, as this article did a really nice job of pointing out. So kind of just to kick off the discussion, Gabe, if you don't mind starting us out, can you kind of discuss, one, the evolution of stem length that was sort of demonstrated very elegantly in this paper, some of the considerations that you think are important when deciding what's the best stem for you, and kind of your approach to choosing the perfect stem length?
Sure. So first off, thank you for having me. Excellent job putting this together, and it's good to see the huge turnout. So obviously the first stems that we had were kind of the standard leg stems, or more of the diaphyseal fitting that we think of. And over time that has become a little bit shorter into more metaphyseal fitting stems. And then ultimately now we talk about stemless. I'm not sure what necessarily is driving the need for this. We think about these theoretical advantages of this, like you mentioned, less blood loss, or, less operative time, things like that. But then other people would argue, well, the humeral stem, unless there's an infection or something like that, usually isn't a problem with loosening. Are we changing things for a reason? And so, when I look at a patient, typically, I don't have any disclosure with this, but I typically use an implant that is a short stem. But I've used the stemless in patients who either have some sort of malunion from a previous fracture. I've seen it used in patients who, may have achondroplasia of some sort. But you want to make sure that it's typically a patient that has good bone stock. I think, initially when we were doing these stemless implants, the idea was males who had, good quality bone, trying to avoid the older female patient whose bone may not be as stable for holding this type of stemless implant. The advantage of it that I've seen is that in that patient population of younger males, they tend to be more muscular. Sometimes it's much difficult to get that posterior aspect of the humerus out and really know your cut. But I think those are the patients that you're really trying to use it for.
That's perfect. And then maybe you can expand, and then Dr. Williams, Dr. Wu, if you want to jump in, what radiographic parameters that you kind of mentioned this do you think are the most important and potentially will translate into the best both functional and clinical results in the anatomics?
So for me, I mean, you can talk about any sort of parameter that you want, but I typically post-operatively am looking at that perfect circle that Ionati and Riccati have described. I'm looking at that medial calcar, that medial aspect of the greater tuberosity and sort of that lateral cortex. I think that's the most important thing to me, to make sure that I haven't sort of overstuffed the joint. I feel pretty confident that the cuff will, not be under a lot of stress. It gives me a good idea that I've recreated what the patient's normal anatomy was, but obviously I also defer to the more senior guys.
Dr. Booth?
Yeah, I mean, just like Gabe was saying, I'm looking at, my neck cut. Did I put it in varus? Obviously this paper shows that can happen with, if you're particularly doing a stemless. My head tuberosity ratio, did I overstuff the joint? And if it's a stemmed implant, did I put it down the pike, or, am I in varus or valgus? All important considerations. And I agree with Gabe. We did stemmed implants for a long time, and they've done well. And some would argue, have we solved the problem that didn't exist? And is it really innovation or just modest change? It's probably just progressive modest changes. People will argue that, stemless has potentially less pain, bone preserving, potentially different types of periprosthetic fracture challenges, etc. I think these are all valid points. And I think, as long as you do the operation well, which isn't that easy, regardless of what you use, then I think that's going to give your patient a good outcome.
Awesome. Dr. Williams, so what are some of the factors that you that go into how you choose which stem length you're ultimately going to do, and maybe some tips that you can give to the fellows as they kind of look through the assortment of options for the humeral stem?
Well, first thing I would say, the one other reason that people haven't talked about as to why we've gone to stemless implants, if you look at the UK registries, the 5-year revision rate for stemless implants is lower, significantly lower than it is for any stemmed implant. So if anything's going to make stemless stick, it will be a decreased revision rate. I don't know that that's been proven in any other registries, but it is in the United Kingdom registry. And from my perspective, I'm old enough where, I saw original stemmed implants that were relatively long compared to what we use today. I designed a resurfacing implant, and the whole thing about the resurfacing implant, even when Steve Copeland used to talk about it, was that it's easier to do. There are less ways to screw it up. And I'm just here to tell you that any one of these options can be screwed up royally. It's not a matter of one that's easier or more producible. It's just the type of error that you make. So with long stemmed implants, if you had really bad exposure, people will put the stems out the lateral cortex. They didn't get them anywhere near in the right place. With shorter stemmed implants, if you look at our paper that we're talking about now, if there had been larger numbers, I think you would have found that the varus valgus alignment was not as good in the shorter stems as it was in the longer stems. So, there are pluses and minuses to everything. And I think that the key point here that I would say is that Mark said earlier, this is a soft tissue operation. And if you don't really understand that, you're never going to get it right no matter what stem you use. You have to really respect the soft tissues. You have to be able to see the anatomic neck circumferentially. The fellows that are on that work with me know that I spend a lot of time taking off osteophytes to make sure that I'm as sure as I can be that I know where the anatomic neck is anteriorly. But I also look around the top of the head to make sure that I know where the anatomic neck is posteriorly. Yeah, where you make the cut is what the name of the game is with the humerus, no matter what stem device you use. And I would sort of encourage people to get away from what the implant looks like and learn the principles that allow you to identify the anatomic neck as well as you can and make the cut there every time.
Awesome. Perfect. So Dr. Franco, can you sort of expand on how do you optimize sort of the humeral side of things? What are some of the humeral side parameters that you think are the most important, whether it's implant or technique, and kind of, expand maybe a little bit on what Dr. Williams was going towards?
Yeah, I think Jerry hit the high points. I mean, the things that I would say now is I've went to standard length stems, and when I did that, I like to undersize them and use bone impaction. I really like that because I could still somewhat have some position of placing the head where I wanted it to. Although in people that have less robust bone, I had to upsize, and that created some difficulty in placing the head segment where I wanted it to. So now I pretty much always will do a stemless because I think it provides me the best ability to get that perfect circle as was discussed earlier. And some of the observations that I make is, I read this paper and I realized when I looked at some of mine, I was making similar errors. So one of the things that I do now, and I would like to hear others' comments, is I'll take the broach and I'll put the broach up to where my head cut is and the shaft of the humerus, and I'll just use that to see, is it look about like my varus valgus cut is about right? And the last two I did, I realized that I had taken off a little more bone inferiorly, so it was in varus. And so what I did is I actually took a portion of the head segment and I grafted that to get it what I thought was more appropriate. And I would love to hear anyone else's comments and thoughts about how they avoid that varus positioning.
Dr. Sperling, do you want to comment about how you avoid the varus position? Any other technical tips you have in optimizing humerus?
I think the key for me is making sure that I do the releases necessary, and I like to use a Brown retractor. So I actually make sure the humeral head is outside the body, so there's no guesswork. So I can see the entire shoulder from the top. Another trick I learned to use a bent Homan from above. You can put that in the plane between the deltoid and rotator cuff. Have a Brown retractor, some Darrow retractors immediately, so you can identify the whole humerus. I still am a fan of using instrumentation of some sort. I think freehanding cuts, even in experienced hands, can be challenging.
We have a question from Dr. Namdari. How close to native anatomy do we need to get to attain a successful and durable outcome? A question mark, elliptical heads, question mark, chamfer comes, question mark, doesn't matter.
I'll take that one. The real answer is nobody knows. I'll give you two ends of the spectrum. Ralph Hurdle, many years ago, when we were in the throes of the discussion about variable neck shaft angles and offset and all those things that we argued about probably 10, 15 years ago, he did a study that showed that there was no correlation between anatomic reconstruction and functional result. And the problem with that paper was Ralph didn't put any in non-anatomically. I mean, his examples that were non-anatomic were off by a millimeter. So, I mean, that's not really the same deal. The other end of the spectrum is I did a study many years ago when I was at Penn to show that if you got the humeral head reconstruction in terms of offset within 4 millimeters of the center of rotation, it did not change any biomechanical parameter. So, I mean, I think for me, that gives you sort of the guideposts. But the real answer is, I think you have to be off a long ways. One of the nice things about the shoulder is that it does have a fair amount of flexibility in terms of what you can get away with, but there are limits. I mean, anecdotally, the closer I get mine to perfect, I think the better they do. But I don't think if you get them 4 millimeters off, it's going to be dramatically different. We don't know about longevity. That's a different question. How does it affect polywear, in a 10-year, 15-year follow-up? But I think the real answer is nobody knows.
Next question is from Dr. Levine. Who is the best master surgeon, Dr. Frankel, Dr. Williams, or Dr. Sperling?
Dr. Levine. Dr. Levine is.
I would actually say any given day, anyone who's on this call could be the best master surgeon. And probably on any given day, we could actually be the opposite of that, unfortunately.
Yep.
I think one of the points that I would make to Bill's point, and the fellows who've worked with me know this, at the end of every operation, I sit down with the fellows and we critique what we did. And I can tell you, I've been doing this 30 years. I still don't get it perfect every time. And so the bottom line is you got to look at what you do, figure out what you did that wasn't exactly what you thought you did, and try to come up with a way to make it better. And if you do that every single day you practice medicine, you'll be a better doctor.
Well stated.
Perfect. If it's okay, let's, that was perfect way to end that discussion. Thank you. If it's okay, let's maybe move on to the second to last article. So Clifton, do you want to go ahead and present the group from the Fauna group?
Yeah, absolutely. So this is title of the study was Outcomes of Anatomic Shoulder Arthroplasty Performed on B2 and A1 type glenoids of a group from Houston. So the purpose of the study was to report the outcomes of TSAs with asymmetric reaming performed on retroverted biconcave glenoids, Walsh type B2 glenoids compared with TSAs in non-pathologic retroverted Walsh type A1 glenoids. And they hypothesized that eccentric reaming of the B2 glenoid can produce equivalent outcomes to routine TSAs in short to midterm follow-up. So this was a retrospective review of a prospectively collected cohort. They had 289 shoulders, which met inclusion criteria, which include a Walsh type A1 glenoid, a B2 glenoid, treatment with the TSA, asymmetric reaming in the B2 groups, and a minimum of 2-year clinical and radiographic outcomes. They assessed postoperative radiographs for radiolucent lines and patient-reported outcomes. Their average follow-up was 40 months for all patients. And more men presented with B2 glenoids compared to A1 glenoids. Age, dominant side, preoperative opioid comorbidities were relatively similar between two groups. Both groups had constant strength scores preoperatively that improved postoperatively. The amount of retroversion for the B2 group was roughly 15 degrees. Their results showed that all constant scores and PROs essentially improved through both groups. They found no significant differences between the A1 and B2 glenoid groups. They found a similar proportion of patients that rated their satisfaction between the two groups. Of note, from a complications perspective, 3 patients in the B2 group had a posterior dislocation. So the conclusion was that although patients with B2 glenoids may present a more technically challenging anatomic total shoulder arthroplasty, with treatment with concurrent asymmetric glenoid reaming produced similar and successful results to the A1s. So my question for the 2 expert panelists would be, what is your overall impression of the results of the study? How does high side reaming versus augments play a role in your clinical practice?
Well, I share a lot of the beliefs of this study, although I would critique it because, as Jerry said, when we finish, we critique what we do. And when we talk about B2 glenoids, they're not all the same. And as a result, the ability to, adequately get good backside contact on really strong subchondral bone can really be a challenge in some of the variations of the B2s that we end up treating. So I don't know that to categorize all B2s the same is the same for me. If I can correct and do a little high side reading and not violate subchondral bone, I think these outcomes are commiserate to mine.
The other thing I would point out, at least where I've gotten into trouble, and I should declare I have augmented glenoids that I design and I use. I think the 2 points I would make is a more interesting thought, I think, in this particular vein. There was also an article recently out of Rick Matson's shop that basically showed that if you didn't even ream the high side, if you just got rid of the ridge and left it in complete retroversion, there was no difference in outcome. And he offset his humeral head anteriorly rather than addressing the posterior capsule with the concept that you leave the humeral shaft where it wants to lie and put the head in the glenoid. I think that's even more thought provocative. To be honest, I'm not sure I buy it. That's just my own bias. And I agree with Mark that they're not all the same. The ones that I've gotten into trouble with is ones, this is years ago, where I really over-reamed the high side and either didn't quite have enough bone to put a glenoid in, or I medialized the joint line so much that the soft tissues were short, and I think contributed to instability. And there aren't too many companies that have increased thickness of polys for this kind of situation, which I personally think if you do enough of these, particularly the bad ones, you're going to wind up needing it or doing posterior capsulorrhaphies. So again, I don't think the answer's in, but for me personally, the ones that I sort of shy away from with augments are the ones that are less than 3 millimeters, and therefore I like asymmetric reaming, and the ones that are really bad, which I have some concern about all poly components in that particular environment. And if the age is right, I'd probably go to reverse and really bad ones.
Yep. Yeah, my philosophy is very similar to what Jerry just said, and I tend to be pretty simple when it comes to thinking about this. When I look at the literature, I think I can correct 10 degrees of retroversion with asymmetric reaming. So 0 to 10 degrees, I asymmetrically ream. 11 to about 24 degrees of retroversion, I'll use an augmented anatomic component, and more than 25 degrees of retroversion, typically I'll go to reverse.
One of the things about that is, you know, I'm one of those guys that's a big anatomic person. I think people know that. But when you start comparing the results, if you look at an anatomic glenoid that you do for somebody with a good cuff and not a lot of bony deformity, I don't care. And nobody on the planet can make it better with a reverse than an anatomic, at least in my opinion. But you start putting B2 glenoids in and B3 glenoids in and trying to figure out how to put anatomics in, and you compare the actual clinical result to reverses, they're not that different. And, you know, from my perspective, I think you got a better shot at 15 or 20 years with a metal augment or a glenoid, a metal component that's on bone like that than you do with an all poly glenoid with an augment. That's just my own bias.
So Dr. Williams, do you have a limit that you that you make that decision? Is there a certain amount of retroversion or a certain amount of posterior subluxation that
well, I
should make
think a little differently. I don't necessarily think about them in terms of angles, although it's perfectly fine. I think about B2s from the standpoint of how, if I draw a line to the paleoglenoid posteriorly, I look at the distance between that line and where the bone is posteriorly. Anything over 9 millimeters a centimeter, I'm not looking to put a poly augment in there. If they're a young patient, I might think about a bone graft with a metal back glenoid. I know that's heresy. But the bottom line is, when I say young, 45, 50, those are patients that I'm a little nervous about putting a reverse in. And if I can get the augment or the bone graft to heal, I've got something I can use later. But if it's somebody in the 60s, 70s, I would say anything over 7, 8 millimeters, I would go to a reverse, even if they have an intact cuff.
Wonderful. And Dr. Moore, since thank you for being on this and wonderful article. So for you, how do you approach these B2? Do you have a limit of retroversion, or as Dr. Williams mentioned, a certain glenoid depth that you are going to shy away from eccentric reaming? And can you expand upon your sort of approach with this approach to B2s, especially those that have a little bit more retroversion?
Yeah, thanks, Eric. Thanks for the question. And thanks for the interest for the panelists. I mean, this has been fantastic. This is clearly a hot button issue, but just to be clear, this is not where we're going. This is where we've been. And these cases, these are Brad Evers cases, you know, tremendous group there in Houston, and Hussein Al-Kuzi in our group there, partnered on this. And this was something that's very important to Brad to put out. This dated back to 2004. So right at the time, the alternative to this would have basically been posterior glenoid bone grafting. There were no augments. So that's a pretty long registry dating back to that with over 1,000 patients. And then the only paper I'm aware of that was published on one of the early cases, at least by Walsh, was in 2013 for B2 glenoids. And those, if you look at the numbers, were probably B3s. So I think part of the beauty of this paper is these were classified initially by Brad years ago after having worked with Gilles. So perhaps his ability to recognize a B2 that would play well with an anatomic versus reverse plays into that. So there's obviously some inherent bias. We did look back at these to confirm that none of these were B3 glenoids, but we lacked the ability to plan these with 3D planning. These are 2D cases, so we cannot speak to that. And he, just like Gilles, got CT arthrograms. So there's no way to go back and look at these and determine, percent retroversion, percent subluxation, all amazing variables. But I think this is just really sets a baseline. Innovation is key. I think augmented glenoid components for an anatomical total shoulder will play out to be effective. We need more follow-up of this patient registry, but it really hopefully sets at least a historic baseline for standard components, eccentric reaming. Dr. Frankel's group pointed this out in 15. The WashU group pointed this out as well in 18, and JSES, both of those. Mixed results, right? Though the WashU data was pretty sound, and I was a little bit surprised by that when I saw it myself. But the notion that all B2s get a reverse is a fairly new concept, and this is old data. So again, not where we're going, but where we've been. And I think the 3D planning, some of the new innovations will help. I treat this just like we've talked about, and Dr. Sperling pointed out, the goal is to prevent the outliers. It's where you put the component, your exposure matters, your preoperative planning matters. So I take this on a case-by-case basis. We don't have the rules of engagement yet. They're going to be evolving. And just for a plug, we have an entire ASES B2 group, and it took us about a year with this amazing group of leadership, most of which are on the call, to determine what is a B2, right? So we've written a whole paper now that we determine what a B2 was, but this is complicated. And even with the vault model, with Eric Ricchetti, Joe Anati, the tremendous vault model, and the Cleveland Clinic resources, we could not really agree upon the posterior bone loss group. So these are complicated, so stay tuned. So that B2, B3 group hopefully is going to use some of this data to really propel us forward. But right now we don't have the answer, but I was really excited to present Brad's cases here. And obviously a master surgeon like many on the call can get the job done. And we've been happy with the results to date, but time will tell.
The other thing I'd like to point out, and I guess it just speaks to the difference in patient populations. Gilles is the only paper that I know of that has high a percentage of females, with elderly females with B2s as he has. I mean, my experience is more like this paper's. I think this paper B2 was something like 80% males. That's my experience. My experience is not only are they males, they're 45, 50-year-old males that like to lift a lot of times. Whereas Gilles was 75% elderly females.
I would add to that, Jerry. When I went to visit those guys, it struck me that the disease of osteoarthritis that they saw was quite different. Not only though were they women, but they had a very small osteophyte, as opposed to, again, the typical osteoarthritis we're seeing, where the head is very large osteophytes. I think they're quite different. And again, I would sort of argue that sometimes we talk about these diseases as if they're interchangeable. And I would probably challenge and say, even the idea of retroversion is a difficult concept, especially if you talk about a B2 glenoid, because it's biconcave. So if you're measuring the version, is it the sum of the two concavities, or is it the more severe concavity? How would one, and anyway, I don't want to go too far into it, but I would just say, pathology matters. How, we're not sure.
One question keeps coming up from a lot of the people attending this is just from the panelists. They want to know, what is their upper limit for high side reaming? I think they just would like to get all your expert opinions.
Maybe we can go through each person. So Dr. Frankel, then Dr. Sperling, then Dr. Williams.
So I don't have a number because I just explained that I have a problem with using that nomenclature. I think if you are critical when you do your planning, you'll see that, for example, if you use one of the software programs, it will give you a number. And if you then imagine what you'll see interoperatively, it in my experience, doesn't necessarily match. So if I can get good subchondral contact with the component and it's secure, that's how I'll approach it.
For me, I think I said previously, or maybe I cut off John. Go ahead.
No, I think for me, the rough algorithm I use is 0 to 10 degrees asymmetrically ream. Some of the literature shows that 11 to 24 augmented anatomic component and 25 or more typically go to reverse with an augmented base plate. Jared?
And I use, as I said, the difference between the extended line of the paleoglenoid and where the bone is posteriorly. 3 millimeters or less, I'll asymmetrically ream. And I'll usually use augments up until 9 millimeters or so. And I say 9 millimeters because the last step we have is 7 millimeters, and you usually ream, you got to put that particular glenoid, you have to ream the anterior half of the glenoid all the way to the midline. And that's usually a couple of millimeters. So if you have 9 millimeters of bone loss, you'll wind up with a 7 millimeter step. Those are general guidelines. I make it sound like it's, you know, one of those things that's very cut and dry. And as everybody who's ever done these knows that it's really not. But I have to say there was a comment on the questions about emphasizing that in Brad's paper, these were mostly mild B2s. And I'd say maybe mild to moderate B2s. But if you look at the article that Rick Matson just published, some of his were, I wouldn't say they were severe, but they weren't mild. And the difference between Rick's and everything that we've been talking about now is he truly does not believe in retroversion. He'll put the component in the retroversion that it lies and just get rid of the ridge. He's the only person I know that actually does that. But he presented his paper and he presented his results. I thought it was pretty thought-provoking.
Eric, Gary, I do similar though. I don't, that's how come my comment about retroversion, and I deflected that is, I don't really, that concept of retroversion, I have a hard time, and the more I try to investigate it, the more it perplexes me, because you're talking about a plane of a surface to another plane, and basically these they don't really fit that. For example, the scapular body is curved. So do you use the scapular body as one of your reference points, or should you use the vol?
Well, if I'm going to be honest, you know, one of the things that I've done for years, sometimes you wind up with a C glenoid or a B3 that you're not sure it was a C and maybe now it's a B3, but the humeral head is pretty much centered on the surface of the glenoid without any subluxation, and the cuff is great. I've put components there, usually inlay components, exactly where they lie, and they actually do pretty well. So, you know, I'm one of the guys that's, you know, Joe and Ianati and I worked together for a lot of years, and we're really wed to the concept of reestablishing the position of the joint line in the medial lateral direction, and also the angle of the joint line, not only antero-posterior, but supra-inferior. And we believe that to my core. But I have to tell you that in my own cases, when I have some patients that have had, you know, some, either they were born with a C glenoid or had some erosion that turned into a B3, I have plenty of patients in whom I put the glenoid right where it lies. And have done pretty well. So I don't know what the right answer is. I just wanted to bring it up because I know my dear friend Rick Matson believes very strongly in this concept. He's a very honest guy and has been right a few times in the past when others thought he was wrong. So I just thought it'd be an interesting concept to talk about.
Thank you very much. If there's no other comments, let's move on to our last article, if that's all right with everyone. So Steve, if you don't mind bringing up our last article. So this is another very thought-provoking and hot and important topic. So, you know, multi-center study with including Dr. Frankel and Pat Denard. Thank you very much for joining us. So this is involving the sort of risk assessment of scapular spine fractures after reversal arthroplasty. So the idea was they were going to sort of tackle some of the previously established risks, whether it's implant or technique or gender, age, a variety of other considerations. And one of their main purposes was looking at glenoid lateralization and implant dislocation on scapular spine fractures. This is a multi-center study done over a 3-year period at 3 different centers, internationally renowned centers. 2 of them use inlay, 1 of them use onlay. And the multiple measurements, as you can see in figure 1, whether you're talking about acromial distance, lateralization of the humerus, and center of rotation offset, for those of you who aren't familiar with some of these concepts. So overall, although there was 37% loss follow-up, there were 426 included, a follow-up of 12.9 months. There were 6.1% overall that were diagnosed with scapular spine fractures. 12 type 1, 9 type 2, and 5 type 3. And there was multiple factors that contributed to this. Interesting enough, not smoking, not osteoporosis. Instead, it was really inlay versus onlay. And at least in this, the onlay group had 12% compared to the inlay group with 5%. Furthermore, chromohumeral distance was 4 millimeters higher in the fracture group compared to the control group, and the inlay group had 10 millimeters less distalization than the onlay group. So ultimately, although they weren't correlated with patient-reported outcome measures, these fractures did produce worse forward flexion and overall activity level. And so in conclusion, this is a great multi-center study, powerful numbers, wonderful radiographic analysis, reinforce some of the mounting evidence looking into both humeral component design as well as certain techniques and ideas of onlay versus inlay and distalization and lateralization. This is kind of interesting, high quality evidence contradicting some of the prior models we mentioned earlier in this talk. Kind of producing some clinical data to support what already is a really growing and robust clinical issue that we have on these chromo fractures. So, Dr. Denard or Pat, if you don't mind starting us out, can you sort of discuss with us a little bit about the impetus for this study, about your view on inlay versus onlay, maybe teaching the fellows a little bit about the consideration versus inlay versus onlay and this idea of distalization?
Sure. So thanks, Eric, for having me. The goal really was, to look at stress fractures of the acromion, basically because it's one of the remaining problems with reverse shoulder arthroplasty. As we know, it's a tough problem to manage and people don't do as well. And when we looked at the literature, we saw studies out there, but they typically reported one implant at a time. So our goal was to really look at three surgeons who use different types of implants so that we could measure acromion distance and lateralization and see if we could see some differences based on that alone. And as you pointed out, that's what we found here when we made measurements based on acromion distance and lateralization. We found no relationship with lateralization, whereas we did find a relationship with increased acromion distance. It just happened that was in the onlay group, right? Because you could take a inlay stem and leave it very proud and end up with the same sort of result. So if you look at the stems, Alex was using a onlay system, and myself, I was using an inlay system that I don't think inlays quite as much as the system that Dr. Frankel uses. And my lateralization was typically about 4 millimeters in this case. And as we know, Dr. Frankel uses one that sits in really well, more inlaid and probably more lateral. So it just allowed us a unique opportunity to look at the different variables by combining them all.
Wonderful. And so real quick, Dr. Sperling and Dr. Frankel, can you touch on this sort of evolution of the humeral stem in the reverse that we've seen and kind of where you see this going in the future?
Sure. So I would just make a couple comments since I was on this. And, as I said earlier, if you read the discussion, this is a direct response to George's finite element study that says if you lateralize, you'll have increased stresses on the scapular spine. And in fact, if you were to do the same analysis with the component geometries that were studied, you would come to the same conclusion as the finite element study. But in fact, the clinical results would be mirrored exactly as we saw that. In fact, the ones that had, a medialized center were more likely to have a scapular spine fracture. So that was one point I want to make. The other point that I thought was interesting, and I certainly want John's input. So there was a study that Larry Galata did on the biomet onset stem, and he talked about how you change the tray position of the humeral implant. If you look at the moment arm of the muscles, it changes relatively dramatically. In other words, as you have an onset tray, because you're offsetting the rotational moment of the humerus relative to the pivot point, it changes the relative muscular forces across the joint. So what that means is that if you have an onset component and you have a lot of cuff muscle, that means as you pivot around that, you're going to have a very asymmetric load across the joint. And as I said earlier, when you talk about, total shoulders or reverses. It's a soft tissue balancing operation. And what I perceive that to mean is when you're done with your reconstruction, as you move the shoulder, you have a sense that the forces across the joint are somewhat symmetric. So when you start placing, again, it's very much dependent on the amount of cuff you have. But if you have a pivot point outside of the geometric center, that center point that Ionati talks about, you start getting an asymmetric load. And I think that that actually has implications of many issues that we don't quite understand.
Yeah, I think it's an interesting issue. And I think what it's evolving into is a more complex discussion than just simply onlay and inlay. Because the data it's conflicting. Again, Routman studied 4,000 shoulders, less than 2%, and this has 13%. So I think it's complex related to what you're doing on the glenoid side, what you're doing on the humeral side, what is the humeral cut you're making. So I think it's more complex than simply an inlay versus onlay. We looked at Mayo, the classic Vermont style, and that had the highest rate in ours out of any acromial fracture. So I think it's a complex issue, and there's a lot more we need to learn.
I think
that's wonderful.
The one thing that we do know, and I'm just going to get on my soapbox a little bit. You know, I have friends that say that, you know, pretty soon we're going to be putting reverses in everybody. If you don't have a conversation with your patient, you're going to put a reverse in about what happens if they get a stress fracture and what the percentage is and how it's going to look. You're going to be a very unhappy surgeon. And until we come up with a reverse design that doesn't have stress fractures, I can't look a patient in the eye and tell them that they have the same complication rate as they do with an anatomic implant. And I think you have to have that conversation with your patients before you put it in them.
That's perfect. Can we go on that? And so as far as maybe teaching the fellows and residents, maybe Dr. Sperling, do you want to start, and then Dr. Frankel, and then Dr. Williams? What are some technical tips that you can give to potentially help avoid these fractures? You know, in this discussion, they mentioned, you know, the location and potential length of the superior screw with type 3 fractures. Anything else can you give to that you try to optimize to help avoid these dreaded complications?
I think, again, it's whatever system you choose to use. I think it's knowing what options you have available to adjust the tension on the glenoid and the humeral side. So I think you able to titrate that for the individual patient is critical. That would be the one thing I would say for the residents and fellows out there. And again, I don't think it's as simple a discussion as onlay versus inlay with all the options available.
Dr. Frankel?
Yeah, I would say the things that I do is I think it's easy to not understand that you can overstuff a reverse prosthesis, because you know, it's easy to try to have some idea about how tight or loose. The other thing is, as I mentioned earlier, and you know, what was brought up by Pat is that, you know, you can have an inset component or try to inset it, but sometimes it's easier said than done because of the geometry of the humerus if it's very small, or if the shoulder's tight. So, you know, I still would say that, you know, this is a soft tissue operation, and the components allow us to manipulate the soft tissue. And one of the things that I don't think we fully understand is the range and variety of the soft tissue pathology. Sometimes the soft tissues are not at all compliant and not susceptible to any sort of lengthening. Sometimes they're patchless, and they really require a fair amount of tension to provide optimal stability and mobility and function. And because we have no really way of studying the soft tissues, we're sort of trying this in the dark. And I think that most of our complications that we're seeing are because of that lack of understanding of the pathology.
Dr.
Dr. Williams, do you have anything to add?
Dr. Murthy has a question. He says, is it really onlay versus inlay, or is it metaphyseal component height? And he was wondering if the panelists could comment on that.
I'll sort of incorporate that into my thoughts. I agree with John that it's a very multifactorial issue. And so to answer Anand's question directly, it probably does have something to do with the distance between the deltoid origin and the deltoid insertion. However you make that longer, it probably does have some relationship to that. I will also tell you that, it's not just about the humeral side. I mean, when I first went over from a Grammont type design to a lateralized glenoid sphere, I think I did the worst of both worlds. I actually still put it at the bottom, but I lateralized it. So I distalized it and lateralized it. That was probably the worst of both worlds. So I think, as John pointed out, know the system that you're using. If you're using a Grammont style implant, maybe put it down a little lower so you don't get as much notching. But if you're using a lateralized implant, you can get away without doing that. So, well, for example, what happens if you would have done this study with a lateralized glenoid sphere that wasn't placed quite as low, but with an onlay humerus? I suspect you would have had about the same number of stress fractures as you had in the group here that was lateralized and inlaid. So I think it's a multifactorial problem. And I think one of the big things that you can do at the time of surgery to try to avoid it is be very cognizant of your superior drill hole. And so, for example, if you're going to use an X-Acto, it's got an oblong base plate. That superior hole, particularly if the superior posterior hole, can get your scapular spine. If you use the one that I use, which is a screw-in base plate, you can't really buy where it stops. It stops where it hits the bottom. And sometimes it stops where that superior hole is superior and posterior. So don't be drilling a 36 hole in that drill hole. I mean, I try not to go any more than 18. And I think there are some things that you can do intraoperatively to try to avoid that.
So I would critique my friend Jerry and say I don't agree with the idea of the screw. We looked at it. I don't think that's the issue. But I would go back to
This paper says it. This paper says it.
No, this paper doesn't talk about screw length.
I think it does.
All type 3 fractures occurred from the superior screw.
Yeah,
but not type 2. So if you're going to avoid type 3s, absolutely.
Well, all right. So, damn it, I didn't read the paper as good as Jerry. But this would be the one thing I would leave with is, if you just thought of shoulder arthroplasty, forget reverse versus total, and say, can we come up with some accepted principles for the operation? I'd say keep in mind the perfect circle that Joe introduced. I think that concept is applicable for reverse as well as anatomic. And if you want to get an idea, if you overstuff the humerus in a reverse, put an anatomic shaped head onto your tray and then see if you have a perfect circle. If you do, then I think your socket depth is probably in that geometric center point. And if you don't, then you probably have some degree of offset between where you're rotating and where the convergence of the ideal position of rotation would be. I think that to me is what I've learned in my thoughts.
I think you're right.
Awesome. Thank you very much. This is absolutely incredible. Anything else before we wrap up? I would like to really once again thank our two contact experts, Dr. Sperling and Dr. Frankel. I want to give a special thanks to Grant Garrigus. He was instrumental in helping us to launch this and to get this started and get this going, get this off the ground and organized, and has been incredible. And then obviously Steve, he's done an incredible work in getting this organized and getting this launched. So Steve, thank you so much. And I would like to once again thank our sponsors and and everybody else at the ASES who's helped us to launch this. Those authors, thank you very much for all your comments. Dr. Frankel, Dr. Sperling, once again, this is wonderful. This will be recorded for anybody who's interested, so please go to the ASES website if you're not able to watch all of it. And like I said, we're going to be repeating this in about 3 months from now, but this time it's going to be on the rotator cuff. So
I would just want to thank you, Chris and Eric, both of you guys, for the initiative, the wherewithal to do this. This is exactly the type of initiative that really distinguish our society, and congratulations. Great job in getting this done. I'm so proud and happy to be a part of it. Thanks again.
Agreed.
Thank you very much. Appreciate it.
Take care.